Like every week, we present one good new topic with a very experienced faculty. So today we are here with Dr. Subhankar sir. Subhankar sir is MD Emergency Medicine, DRNB Critical Care. So sir has accepted my request to discuss about ECPR review and clinical applications, which is very important and a new topic for emergency physicians. So that's why we are here today. And thank you, sir. Please start the discussion.
Thank you, Nan, for this nice introduction. Anyway, so ECPR is a very recent topic. It's a recent topic of interest among all, like among intensivists, among emergency physicians as well, because everyone has to know it. Everyone has to be trained in this skill, like within next few years as well. So you'll have a very short review of ECPR, that is extracorporeal CPR and its clinical applications. Mostly we'll try to understand the principles of ECPR, some review of the current evidence, what are the indications and outcomes, like the patient selection criteria, which is the most important for doing ECPR. We'll discuss a bit of ethical considerations and logistics exactly. So without wasting time, going to start. So basically, sudden cardiac arrest, if we see that it's a leading cause all over the world. In USA, we have the data. It's like 6 lakhs 40,000 episodes of sudden cardiac arrest occurred every year, and of which about 3 lakh 50,000 are out of hospital cardiac arrest, and 2 lakh 90,000 are in hospital cardiac arrest. And it leads to severe mortality as well as morbidity. In USA, we don't have exact Indian data or many other developing country data, but if you see, it's a very high. It must be very high. And obviously, in the sudden cardiac arrest is a very much leading cause of death. Okay. And
Sir, you're on mute.
unmute only. Audible?
Yeah, yeah.
So previous things were audible or not?
Yeah, it was audible. Just now it went on mute.
I don't know what happened. Okay. So if you see that after OHC, out of hospital cardiac arrest, the survival rate was typically less than 10%. Whereas in IHCA, usually the survival rate is more or less 50 to 34%. Okay, so ILCOR, that is the International Liaison Committee of Resuscitation, they recently have a guideline. Like from 2000, I think it's of 2021, they have released a guideline on ECPR. They still now have just considered it as a rescue therapy for selected adults for both out of hospital cardiac arrest as well as in hospital cardiac arrest, where the conventional CPR is failing to restore the spontaneous circulation. But the everything of, I mean, all the things are still in the very preliminary stage. The guideline is not concrete, and it is not backed by too much of evidence. So we'll go into details of all of this. So ECPR is still now, it is not universally considered as a standard of care. So it is available obviously in a very few specialized centers due to limited availability, limited evidence of benefit, high cost, resource limitation, and all those logistic requirements. So what is basically ECPR? So basically it is a extracorporeal CPR, or the definition is it is initiation of VA. It is no VB ECMO, it is only veno-arterial ECMO during resuscitation of the refractory cardiac arrest to restore the adequate blood circulation and tissue oxygenation when conventional CPR cannot achieve a sustained return of sustained ROSC. So I have highlighted two words there. One is a refractory cardiac arrest, one is a sustained ROSC. Can anyone from the audience can tell what is this? I mean, what, refractory and what is a sustained ROSC means? Anyone in the chat box? Okay. Now there is definitely okay. Then I go by myself. So refractory cardiac arrest. Then again, there is no definite definition of refractory cardiac arrest. These there in different trials they have mentioned different criteria for refractory cardiac arrest. In general, if there is no ROSC within 5 to 30 minutes after the initiation of ACLS, it is considered as refractory cardiac arrest. Now, arrest trial was there which considered the refractory VT related cardiac arrest was like even after giving 3 shocks for the VT or via pulseless VF, there was no ROSC, then they have called it a refractory cardiac arrest. And sustained ROSC means the when after the return of spontaneous circulation, the chest compressions, further chest compressions are not required for at least 20 consecutive minutes. Then it is called a sustained ROSC. So, if in a patient who is having a refractory cardiac arrest and we are not being able to achieve a sustained ROSC by doing conventional CPR, we can aim for ECPR. The aim is to provide a very rapid and adequate perfusion to end organs, particularly the brain, and by the time to manage the potentially reversible conditions thereafter. So, if you see the conventional CPR, it can provide only 25 to 30% of the cardiac output, whereas the ECPR, it as you know that it can provide a complete 100% of the circulation as well. So it can achieve this adequate end organ perfusion, particularly brain perfusion, very rapidly, and the low flow duration can be minimized. So it can initiate a potential good neurological outcome if we can initiate it timely in selective patients. And mostly the aim is to breach to, it is not breach to decision. Breach to decision is for VA ECMO. For ECPR is a breach to, either it can be breach to recovery, it can be breach to death, or it can be breach to some long-term support, or breach to the transplant as well. So if we see that the resuscitating very sick patients using this portable cardiopulmonary bypass, it's not new. It was in fact started and reported by Matoxetol in 1976. So how did this bypass machine research evaluated into a modern ECMO, evaluated into integration of this ECMO system, ECMO principles in uh, cardiac arrest scenarios? So by the development of the ECMO technology, like portable and miniature extracorporeal machines, if you have seen that the modern day ECMOs are very much portable, small machines are there, and it is not that much cumbersome bypass machines. Previously, it used to be in the OT. And we have also used bypass CPB machines for providing ECMO, particularly during the COVID times, where there was a deficiency of modern small portable ECMO machines. With much more research, now the Indian version of the ECMO machine is also going to come very soon. So you have a portable miniature machines which are going to make our lives easier to provide ECMO. So, and also the pre-assembled circuits, pre-percutaneous cannulation techniques have improved over the time with the use of ultrasound and all. So all these things, and also the training improved understanding of the intensive physiologies of the patients in this kind of patients, and implementation of guidelines, and overall improvement in the general emergency and intensive care, overall improvement in the technology, overall improvement in the engineering, in the medical science. So it has led to this evaluation of ECPR. So the basics is that VA ECMO, I have told that there is no role of VB ECMO. The ECPR is completely of a VA ECMO, veno arterial ECMO. So it will have its like circuit components, cannulas, pump, and oxygenator. So if you go to the basics, the most common configuration for ECPR is a femoral vein, VA ECMO. Okay, so like in this picture, you can see the IVC, femoral veins, everything is marked, aorta is marked. So the most common the access will be, so just a minute. Okay, so most common access is femoral access, because we have a paucity of time. We have to take the access very rapidly. So we will take mostly one femoral vein and artery will be inserted, and sometimes the both sides, one side vein, one side artery can also be accessed. Okay, so large bore cannula are introduced by Seldinger technique, or if the Seldinger technique cannot be achieved by within 5 to 10 minutes, then we can do open access also. But open access will only be done by CTS people, obviously. For ECPR, like for instituting a conventional VA ECMO, we have to decide the arterial size, the venous size. We will take multiple. We'll do the sizing and all. Okay, which size cannula will be best or perfect for the institution of the VA ECMO. But for doing ECPR, you should not take so much of options. Like during intubation, also during crash intubation, for male patient we use a simple 8 size. For female patient, use a 7 size. Thereafter, you can do anything. So similarly, during ECPR also, you use a simple vascular access cannula of like femoral vein. It is a 21 to 25, or you use simple 25 French, and for artery, you use a 19 French. Simple. only single size, you use it. Sometimes you should have a smaller size in reserve. In case it is not going, then you can insert a smaller size. Okay. And mostly with improved training, this procedure can be completed in less than 10 to 15 minutes. So whenever we have decided that we will go for a VA ECMO in a ECPR scenario, then within 10 to 15 minutes, we can institute with experienced hands. So another important thing is the distal tip of the venous cannula. Distal tip of the venous cannula should be positioned in the mostly in the RA or the superior vena cava as well. And the distal tip of the arterial cannula is positioned at the aortic bifurcation or in the common iliac artery to have the best kind of support. So whenever we will take the blood from here, so venous from venous system, we will take the blood, we will go through the pump and through the control panel, then the oxygenator will be here. So the venous blood will be oxygenated and the oxygenated blood will be return to the arterial system. So the circulatory system will have a good kind of support and adequate perfusion. Problem with this VA ECMO happens is that the VA ECMO cannot provide a very good circulation for the heart itself, for the coronaries. So during the VA ECMO or the ECPR, after instituting the VA ECMO, your brain will be perfused very well, kidneys will be perfused very well, all the major organs will be perfused very well, but there will be scenario when the heart itself can be compromised. I'm not going to in details of it, but remember this thing that VA ECMO is not that very good for heart itself, but it can provide a very good circulatory support. So ultimately, the ECPR provides the extracorporeal gas exchange and mechanical circulatory support for the cerebral and systemic circulations, gain time to address the underlying condition that lead to the arrest. So it can be AMI, it can be a poisoning, it can be other any um, any reversible cause of cardiac arrest, which is not being revived. So it is ECPR, the physiology, as I've already discussed, it restores the oxygen delivery and perfusion. It reduces the ischemic injury during the low flow state and supports the bridge to recovery or bridge to intervention. Now coming to some discussion of the evidence regarding ECPR over CCPR. Unfortunately, for in-hospital cardiac arrest, we don't have that kind of data which like particularly we don't have RCTs which support that the ECPR is superior to CCPR for in-hospital cardiac arrest. But we have multiple retrospective and prospective case series and studies which say that definitely it has a better ECPR has a better neurological outcome, meaningful neurological outcome, and favorable survival at hospital discharge, and even better neurological outcome after 2 years of the after 2 years. So for in-hospital cardiac arrest, till now we don't have proper RCT back data. We have meta-analysis also, which says the extracorporeal CPR is better, but all those are meta-analysis also are backed by observational studies only. There is no RCT, unfortunately. Maybe in near future there will be RCTs. But still, if you see that in hospital cardiac arrest, definitely in properly selected cases, the outcome should be better. Logically should be better if we can select the patients rationally. And we can select the patients very when they're, I will come to the indication or selection criteria. So if you can select the patient very well, then definitely ECPR will have better outcome. But obviously the RCT is needed to prove that thing. But logically speaking, it should be better in hospital because the setup is there, the everything, the preamble is there, like the intensively, the nursing support, everything is there, the circuit is there. So you can institute it in very less amount of time and can have a better recovery. Whereas for out hospital cardiac arrest, there are some data. There are three major trials. One was a arrest trial, one was a Prague HCA trial, and one was the Inception trial was there. Now, among these three trials, I'm not going into very details of this trial because it makes very dry. So arrest trial, it was even stopped very earlier because it had showed a betterment, significant better outcome of ECPR than the CCPR. Okay. However, the Prague HCA and Inception trial, though they have very many positive points, but overall there is no statistically significant survival benefit of both the Prague HCA trial or Inception trial. However, most of the things, most of the parameters, many of the parameters, in fact, shown there was good more beneficial benefits of ECPR than CCPR for out hospital cardiac arrest patients. So nowadays, like these trials they have occurred. So also in India, also in fact Singapore and many other places they are performing this pre-hospital ECPR. So on-scene cannulation teams they are available in Singapore also, Paris, London. They have on-scene cannulation teams. They can, if they can institute ECPR very rapidly, it can reduce the low flow time for OHCA, and definitely it has a logistic and resource challenges. So they have several kind of models. I'm just showing the models. Like one thing, if there is an observed cardiac arrest, okay, so there can be three scenario. Oh, timely and effective bystander CPR is a must. The CPR must be started. Once the team arrives, the ambulance arrives, then transport to the initiation hospital. ECPR initiation is the hospital in the ECPR enabled hospitals, and then it can transport those patients to specialized ECPR center. Okay. Now another thing can occur that after the bystander CPR, they can transport to the ECP specialized hospital who have the ECPR facilities as well, and then the ECPR can be instituted, and whatever post ECPR management can be done in that hospital itself. Now the third thing is on scene initiation of the ECPR, and thereafter it can be the patient can be transported in the ECPR specialized ECPR center where the further management will be done. But the most important thing is that effective bystander CPR on scene, timely decision about this ECPR and transition to ECPR so that the low flow time can be minimized, and the on-scene cannulation and initiation of the ECPR, if can be performed, probably it will be the best for the patient. Probably it will be it will have the best neurological outcome. Okay. Now coming to the patient selection criteria for ECPR. Now this is a very busy slide. There is, and but till now there is no definitive guidelines. Till now there is no definitive inclusion or exclusion criteria. The several trials have uh, selected patients based on several criteria. Kelso guidelines say something, ILCOR guidelines say something, IHA guidelines say something. So overall, if we see that the patient's age, if the patient's age is less than 60 or less than 70, they have a better outcome. If the initial rhythm is stable rhythm, sorry. Okay. So if the patient's age is less, if the initial rhythm is a shockable rhythm, if during the CPR, particularly for in-hospital CPR, the ETCO2 is more than 10 and diastolic BP is more than 20. So, and the if for the out-hospital cardiac arrest, if there is a bystander CPR has started and ROC time is like no ROC time is less than 5 minutes or 5 minutes. So this kind of patient can be benefited from ECPR the most. However, a very less age and very extremes of the age. If the age is 18 years or it is more than 75 years, CPR duration less than 10 minutes, known severe irreversible brain damage, terminal malignancy, post cardiotomy shock, acute aortic dissection. These are the patients which are not the candidate for ECPR. So the recent publication in the Lancet, they have characterized, they have not given any specific inclusion or exclusion criteria, but they have characterized into three vague zones. One is a portion where there is a stop criteria. Like if there is no flow time more than 10 minutes, unwitnessed collapse, no bystander CPR, frail or older people, severe known terminal comorbidities, and if there is a patient is having advanced wishes against CPR or ECPR, and already if there is prolonged global hypoxemia. This is a very important. If the pH is very less or the PaO2 is less than 40 for more than 2 hours, then any of the stop criteria, if it is present, then ECPR should not be done. Whereas if the patient is having like witnessed collapse, no flow time to no flow time less than 5 minutes, effective bystander CPR, if age is less, initial shockable rhythm, any signs of life during CPR, and estimated time to ECPR is less than 60 minutes after collapse. So suppose a patient has collapsed, we have started CPR. Within 5 minutes, there is no ROC. We have alerted the team. The ECPR team comes immediately within 5 minutes. So 5 plus 5, 10 minutes has already elapsed. Now the attendant counseling and all these things, it has to be completed within 5 minutes, and some team must be ready. So around 15 minutes has already gone. The conventional CPR is ongoing. So after when the ECPR decision is confirmed, then we go within 15 to 20 minutes, we have to institute the ECPR. So if you see that institution of this ECPR and the time of the cardiac arrest, if it is less than 60 minutes, estimated time is less than 60 minutes, definitely we should go for it. Okay. And obviously, if there is accidental hypothermia leading to collapse, then we have case reports of very long-standing CPR and rewarm after rewarming the patient, we do the CPR, then we get the benefit. In those kind of patients, also ECPR is very much a pro criteria. Whereas if there is a vague zone, like if there is unwitnessed collapse, but probably very short latency of collapse, probably, most probably, if the age is less than more than 75 years and initial rhythm was non-shockable, if ETCO2 is less than 10, NRS 16 less than 16%, estimated time to ECPR is more than 60 minutes but less than 75 minutes. Very high risk, but acute comorbidities, not chronic, but very high risk chronic comorbidities. Very high risk acute comorbidities, any comorbidities with substantial effect on quality of life or life expectancy. So this kind of patients, you should discuss with the team and take very rational decision whether we should go ahead for ECPR. So this is a vague zone. This is a vague zone where the practicing physician, the intensivist, the ECPR special, the ECMO specialist, and the primary specialty team, they should jointly discuss and go ahead for the ECPR or no. Okay. Now the flow dynamics. So as I have told only the step one, obviously you have to identify the cardiac arrest, mostly for the IHCA. So you have identified the cardiac arrest and the conventional CCPR is more than 10 minutes. In fact, whenever the conventional CPR is going for more than 5 minutes, we should alert the ECPR team if they are available. Now, is ECMO team alerted? ECMO team alerted the inclusion. We have to go through the inclusion and exclusion criteria. Now, okay, go through the inclusion and exclusion criteria. And the step feed is most important. The ECMO team arrives within 5 minutes, or they have to be either available, a designated ECMO team, or they have to be like some kind of system when they can be assembled within all the existing members who are presenting on the duty. They can be assembled as an ECMO team, a VA ECMO team. Okay, so they have to be assembled. So monitor CCPR should be going by the conventional CPR team. That is mostly the ICU team or the ER team, whatever. Now ECMO team arrives and they set up for the access. We have to set up for the access, do the dressing, draping, everything ready. And another team, mostly comprised with the either the head of the head of the intensivist, one specialist, primary specialty team, and one the ECPR team member. These three persons at least they should discuss with the family member whether to go for ECPR or not. Now here lies the most difficulty, in particular in the Indian scenario, where it is so much of research intensive procedure, and we don't know whether the outcome will be good or bad. So we have to, but somehow if there is something, we have to make the patients, make the attendants agree to the ECPR. So within 3 to 5 minutes, because time is bread, you cannot waste time. So within 3 to 5 minutes, if we can get the consent, whenever we get the consent, the ECPR constituting team, so we are already ready. So they will start accessing. They will start the cannulation. So they will first take the venous guide wire will be inserted. The heparination will be done, and they will take the venous, then artery. Immediately after the venous and artery initiation, so the venous and artery access will be taken. So if the percutaneous access cannot be achieved by 5 to 10 minutes, then you have to call the CTV surgeon to take an access by surgically. Okay, so we have to initiate the you have a cannula, insert the cannula, and after inserting the cannula, we don't jump for initiation of the ECMO. Here is the catch. Just I will show the next slide. Yeah. So immediately after, whenever the cannula has been inserted, it has been confirmed that cannula has been inserted. There is no leak in the circuit. There is no bubbles in the circuit. We have to finally confirm it. Then we start the full 100% oxygen. We start the sweep gas flow in the oxygenator, and we start the ECMO machine console. So we will start the RPM at least 1500 to 2000 RPM. We will start. Then we open the venous cannula first. Then we'll open the arterial cannula. Thereafter the arterial cannula. So at least the initial RPM has to be achieved. So at least 3 to 4 liter per minute ECMO blood flow should be achieved. Then after admission of the ECMO, then we discontinue the CPR. So before achieving the RPM of RPM sustain, RPM, which is enough to generate a flow of 3 to 4 liter of ECMO, we cannot stop the CPR, conventional CPR. So we have to continue the CPR till the ECMO blood flow has achieved a 3 to 4 liter per minute flow. Then, if it is confirmed, then we discontinue the mechanical chest compression and then we continue with the ECPR or the ECMO. Okay. So during this whole process, like you will get mostly 30 to 45 minutes time or maybe 1 hour also. When we went for the ECPR training, we were given the scenario where we had to complete, we have to initiate the ECPR within 20 minutes of 20 minutes of arrival of the ECPR. So we went as a ECPR team in the dummy. We had to counsel the patient. One team was ready with the conventional CPR and one team were ready with the ECPR technique. Then when we got the confirmation from the attendant, we instituted it. And if you could not institute it within 20 minutes, then you are supposed to fail. So by that, our training happened in ECPR. Okay. Now coming to the post ECPR management. Obviously, the post ECPR management is not too much of different from the conventional post arrest management. The conventional post arrest management will be there, plus conventional routine VA management will be there. Some ECPR specific immediate post cardiac arrest management I have outlined here. Now, immediately after doing the ECPR, as you know that now, during the ECPR institution, it's not a very routine, stable patient you are inserting. You are inserting in a patient who is where the active cardiac massage, active CPR was ongoing. So, immediately after generating the ECMO flow, then you have to confirm the access cannula and the return cannula position, either with the fluoroscopy or you use the transesophageal echo or TT, it's your wish, but you have to first confirm the cannula position. This is the most vital thing. Now, map management is again one thing that is then you have to take a right-sided arterial limb cannulation, because this will be the best thing, the right-sided arterial limb cannulation, best indicator to have to look for the native circulation PaO2. Okay. Now, third is the temperature management. Now, again, it is interesting thing that targeted temperature management in Nagaon et al. In 2010 only, they have reported 171 patients who had unsuccessful CCPR, all underwent ECPR with IABP. Now, they were followed by PCI, mostly whenever needed. Now, they were maintained on a hypothermia of 34 degrees centigrade for 3 days, and 12% had a good neurological recovery during hospital discharge. And neurologically favorable accuracy of 85 to 88% were reported in patients with cardiac arrest to CPB interval of 55 minutes and CPB to 34 degrees centigrade interval of 21 minutes respectively. So usually for ECPR patients, the present guideline or recommendation, whatever you call it, the general consensus is to maintain a body temperature of 33 to 35 degrees centigrade for a 24 to 48 hours. Okay. Now, optimal map target is in during ECPR, as the circulation is taken care of by the ECMO machine. So we can target a bit lower side. It should be map target more than 60 millimeter of mercury is adequate enough for having a good organ perfusion, and less than 80 millimeter of mercury should be there. The map should be there to minimize the risk of LV distension. Because if you give a very high flow of VA ECMO, then I have already told that it is not that much good for heart. So the antegrade flow from the heart will be obstructed by the retrograde flow from the arterial cannula. So ultimately, the LV afterload will be increased, the LV distension will be increased, there may be LV stunning, and post-stunning management we have to do by LV venting. So it is better to maintain the map less than 80 millimeter of mercury. Okay, titrate the sweep gas flow and all these things to avoid the hypercarbia. And other VECMO, routine VECMO management, you have to do like this. Okay. Now coming to the complications, like as with any other VA ECMO, obviously ECPR, all the complications will be similar to the any VA ECMO or VB, mostly VB ECMO. Like neurological complications, there may be bleeding, hematologic complications. Obviously, there may be hemorrhage and diffuse hemolysis and DIC, diffuse pulmonary hemorrhage, diffuse alveolar hemorrhage, is a very braided but common complication. And I have already told for cardiac, like for VA ECMO, that is ECPR, there can be chance of early cardiac tamponade immediately or very within few hours of initiation of the ECPR. There can be chance of LV stunning very quickly. So this kind of cardiac complications can occur. Now, infection, obviously, another problem because ECPR, during ECPR, the maintenance of the sterility is a must, but sometimes, obviously, it can be compromised. So, there is a very high chance of infection as well. So, bacteremia or septicemia can occur very frequently. Line-related infections as well can occur very frequently. Other device-related and circuit-related complications like cannula misposition, vessel perforation, cannula side bleeding, limb ischemia, particularly for ECPR as it is a VA ECMO. So we have blocked the arterial flow to the distal limb. Whenever we have inserted the arterial cannula, so we are blocking the distal limb perfusion. So after instituting the ECPR, within 75 minutes to 2 hours, we should try to insert a distal limb cannula to the same artery to provide adequate circulation for the distal limb. Otherwise, distal limb ischemia is going to happen. So that is one point, that when we are taking the venous and the arterial cannula in both in the same limb, so that also increases the chance of distal limb ischemia, venous stasis, and everything. So we have to be very careful about that. So most of the complications in ECPR are common to the routine ECMO, and most common complication which you don't want to see is bleeding. This bleeding is a very common complication. You have to see why the patient is bleeding. You should believe on the TEG value rather than of individual value. Even if the platelet count is normal, but TEG, if you see there is signs of functional thrombocytopenia, you have to insert, you have to give transfuse platelets and all. So you should believe the thromboelastography values, TEG or ROTEM, for bleeding management. Okay. And vascular injury, I have already told, leg ischemia, sepsis, and all, everything. Some tips are there that for percutaneous femoral access, ultrasound you have to use after accessing the fluoroscopy or TE echo for confirming the positions. And interesting thing is that percutaneous cannulation is associated with a lower risk of severe neurological complications and fewer local infection than surgical cut down. And again, bilateral cannulation might be associated with lower risk for peripheral limb complication, as I have already told. Okay, so in India, there are scope of plenitude of ethical considerations, plenitude of ethical dilemma, financial dilemma, legal issues, everything we can face because it is this thing. It is not routine. And again, another thing is that after you institute the ECPR, then it's very difficult to switch off that ECPR ECMO machine, because attendant will obviously see that perfusion is maintained and everything when so withdrawal decisions are very vital here, but very difficult to make. Whenever you have instituted everything in the like it's a bypass, the attendant will maybe obstructing your withdrawal decisions. Okay. So you can ultimately you will go on with ECPR, we will go on with VECMO. There is futility. There will be prolonged futile support. There will be a prolonged financial burden. Then after the final death declaration, the attendant will come. They will say so much of bill and so much of bill has been generated. So you should have stopped early. And all these things, all this dilemma, these ethical considerations, you have to go through it. You have to go through. You have to make a institutional protocol for dealing with all these kind of ethical considerations. Again, another thing, like suppose a patient is in hospital, he has undergone in hospital cardiac arrest. Now you are going to start an ECPR. Now for ECPR, who will be at the cost? The attendant. If it has occurred during any procedure, suppose in the cath lab during doing some PCI or any high risk procedure, patient has got arrest and we have to institute ECPR. Now the cardiologist has to persuade has to make the attendant agree to the procedure, but who will be at the cost? whether the cardiologist should be at the cost, whether the institution should be at the cost, or whether the attendant themselves should be at the cost. So this is one place, this is one thing that needs a institutional level, a management level discussion. There may be some solutions by, I mean, if you are trying to institute an ECPR program in your institution, then you have to talk with your management in terms of that. There may be some losses, definitely some losses, but which can, but if once the program will be settled, once the program will be started, there may be some loss which can be incurred to the hospital. But ultimately, in the long run, it is going to be a good success. But they have to take that initial risk, and they have to take that. They have to grant that kind of financial support to run this program in an institutional level. Okay, whether we can do organ donation after ECPR. Now, in some studies, it has been observed that ECPR can also be used for a bridge to neurological assessment, and potential has the potential to donate the organ, particularly donate the organ, particularly for the non-survivors. So, and because the overall brain circulation, overall circulation to the all the other peripheral organs are maintained, so it can be a very good way to institute ECPR who are potentially brain dead or just potentially brain dead patients, and then we can, in fact, promote the organ donation. But all these things are very vague. Till now, is seems to be very difficult to start with. But obviously, these things needs institutional level discussion, government support, and everything. Thereafter, it can be sorted out. Okay, another debate is cost effectiveness. Obviously, the high upfront resource utilization is there. So the either the government hospitals or the like hospitals which have a public-private partnership, they are probably the better place to institute it. But for the corporate also, if you see that initial labor intensive and initial resource intensive, but ultimately the patients will have a good neurological outcome, a good quality of life. So if you see from that angle, then this initial utilization of these resources or initial utilization of these finances can be justified, because in many of the studies they have shown that there is around 70 to 80% good neurological recovery after instituting ECPR. Indian scenario, as I have already told, that limited adoption due to limited availability, limited training, and also the logistic cost and infrastructure barriers. And but however, the in the urban cities, in the major corporates, the interest is growing, particularly for the hospitals who are already running their VA ECMO program. They are taking interest that whether they can go to another level by instituting ECPR program. Institution checklist for ECPR readiness. Obviously, 24 into 7 ECMO team availability must be there. Trained converters. Pre-prime circuits is not always a possibility, but with experienced hand, whenever you decide to institute, the circuit can be primed within 3 to 5 minutes. Can be primed within 5 minutes. So your cannulation times, you take that kind of time, 5 to 10 minutes, and within that time, the circuit can be primed. Mostly. With training nowadays it can be achievable. So even without pre-prime circuits also, we can do priming very rapidly and can institute ECPR. And transport pathways and post convolution ICU plan also have to be decided in prior. So for the students or the residents, the first thing is to go for a training in ECMO, VV ECMO and VA ECMO. And once you are doing the VA ECMO in a high fidelity simulation, that is very much essential. Then you go to on practicing VA ECMO, you do an observership. Thereafter, if you are being a proper participant of our ECMO program, so after you have at least 10 VA ECMO experiences, then probably you can aim for a ECPR program or ECPR starting of ECPR in any of your patient. So what are the future directions? As I've already told that one is the pre-hospital ECPR expansion, refinement of patient selection tools, portable ECMO system, improved neuroprognostications, organ donations may be a possibility. I don't know yet, but these are the possibilities. So take-home messages is that the ECPR is a teamwork requiring multidisciplinary expert, highly skilled health workers, and adequate infrastructure with appropriate devices must be available. And there are lots of ethical, legal, and financial issues that need to be considered before ECPI initiation and while withdrawal of the support also that is necessary. So this resource intensive therapy can be only be successful if the initiation since the arrest is very less. So less time for initiation, very less no flow time. The equipment should be all the equipments must be there, and the personnel who will be there, they must be highly interested in their work. Obviously, they have to be fully dedicated personnel and a full teamwork who will work 24 into 7. Then only the ECPR can be successful for saving lives. So if you want to read further on ECPR, I have already told that 2021 ILCOR guideline, this also guideline is there, and another very recent 2025 article from the Lancet.
Sir, you're on mute.
So, as I was telling, yeah, if you want to go through much details, there are multiple articles, but one of the most best two articles I can tell you. One is a ELSO guideline on ECPR, which was published on 2021, and the second one is the 2025 Lancet review article. It is also very good, and it is published only in May 30, while we were doing the training program. So you can go through these articles for a further comprehensive understanding. Okay, hopefully I have given you some kind of idea regarding ECPR. So if you have any question, you can ask me. Thank you.
Thank you, sir. Thank you for a very comprehensive discussion, and you have given us a brief of ECPR for even a beginner level to understand very briefly. Thank you very much, sir. We'll take some questions.
Yeah, sure. I have tried to make this simple by not going into too much of depth of VA and all. Because I think, I mean, without a basic idea of how the VA works, it is really very difficult to understand how, I mean,
So
what will be
to
the
summarize,
most
to summarize, when a patient we witness in the hospital, patient cardiac arrest, so what is the criteria? Like you have already told, just to summarize it, there is a pH criteria, there is a rhythm criteria. So can you just tell us briefly, because for people who have joined late.
Hmm. So I think this is the most important slide of today's evening. There are three things. One is a like stop criteria. There is no definite criteria as such. There is no universal criteria. There are some things you need to understand where in which kind of patients, if you select, there can be a meaningful neurological and other organ recovery. And there will be some subset of patients where even if you institute an ECPR, there may not be a meaningful neurological recovery. So you have to identify those kind of patients and take decision accordingly. The stop criteria, if there is any kind of stop criteria, like if there is no flow time of more than 10 minutes, if there is unwitnessed collapse, no bystander CPR, very frail and older people, severe terminal comorbidities, and if there is patient is having any advanced patient wish regarding against CPR, and prolonged global hypoxemia. If these criteria are there, definitely it is a no for ECPR. Now, on the contrary, if that is a witness collapse in our OHCA patient, if there is bystander CPR, effective bystander CPR, age is less than 65 years, there is no flow time, initial shockable rhythm, and if there is no acute comorbidities or there is like generally treatable acute comorbidities, no very chronic comorbidities, or if there is accidental hypothermia as a reason for cardiac arrest. And also another important thing, the estimated time to ECPR is less than 60 minutes. So if these are the things, then you can definitely take a chance with ECPR. Now, in between these two, there is a gray zone where if there is unwitnessed collapse, but probably very short latency since collapse. So you have probably unwitnessed collapse, but probably it has not occurred too much soon. Okay, too much before. So you have started CPR, bystander CPR. So that can be a WHCA scenario. If the age is more than 75 years, initial rhythm is non-shockable, But still, if you think there is some kind of like some signs of life, or during the if you are giving effective CPR, you can take a chance. Estimated time to ECPR is more than 60 minutes after collapse, and high risk acute comorbidities, ABG, if the pH is less than 6.7, this kind of scenario, you have to take a decision with your team, both the ECPR team and the intensivist team, whether we should go ahead with ECPR. Because even if you institute ECPR, whether I mean, we should take that chance so that the patient have a good, meaningful neurological recovery. That is our aim. So you have to take decision judiciously among this gray zone of patients.
Okay, thank you, sir. Thank you for again going through the summary for just for our sake. So, sir, there's a question. What is the preferred manual compression or automated compression device while cannulation?
Yeah, so the study have done one study, I don't remember. The studies have shown that even if you, I mean, manual compression device, if you can use, definitely it will help to remove the staff fatigue. Otherwise, for recovery per se, both of the things like comprehensive the manual compression versus mechanical device compression both have similar outcome. So if you have a device, use it because it will then the other stuffs can be those staffs can be those at least 2% can be freed and they can be utilized in other things during the ECPR. So if you have it, use it. Otherwise, you don't worry. You go on with your conventional CPR chest compression technique and it will have a similar recovery rate.
Okay, sir. Thank you. I think we are also completed the 35, 40 minute mark. So that's all for today. We'll post this video on YouTube very soon so that everyone can access it. So keep following us for a weekly session on such interesting topics. Thank you very much. See you all.
Thank you, Nan. Yeah.